It's just so exciting to hear all this stuff that we talk about in like at the pub or at work. It's just like we need to do more. We need to look at a system level architecture, get right up to the top and look at the mega systems like schools, like public health, and for that to be happening just makes me overjoyed, because not-for-profits can fight tooth and nail every day and psychologists in one-on-one meeting rooms, but until the whole system gets on board, we're still going to be facing this epidemic. So really, really exciting stuff. Thank you, Stephen. So, where are we in my notes here? Alright, so we have a panel discussion now, which is very exciting. So I'm going to introduce 3 people down. We're going to bring some chairs up, I think. Yeah. So first of all, Lucy Brogden, the chair of the National Mental Health Commission. Carmel DeVoe. Tebbit. Okay, so there we go, Tebbit. CEO of the Mental Health Coordinating Council. And Catherine Lowry, New South Wales Mental Health Commissioner. I think you're staying up here. So, yeah, exactly. This is a star-studded lineup. This is your chance, guys, and I'm pretty sure everyone's going to want some questions. So are we just going to fire at will? Yeah. Are we feeling okay here, guys? All right, good to go.
So I think we should start by giving our 3 leading ladies an opportunity to respond to what Dr. Stephen has just given us, and then we'll hand over to the floor for some Q&A style panel discussion.
Well, thank you for all that prep time you gave me to answer that. So, first of all, I should really say thank you to Stephen for travelling around New South Wales and Australia. When I last spoke with Stephen and his team, like I said, I really wanted to thank them for their courage, because we all know in mental health being courageous is really important. And that's about standing up to discrimination, standing up to stigma, and it's about getting equity across all the domains of a person's life. And I think that's really what we want out of a review that's into how we fund our systems. And I think I really resonate with your point around having evaluation built in from the beginning. Of course, I would say any evaluation has to be done in a co-design process, because we want outcomes and evaluations which are relevant to people, their lives, both the systems and our workforce, so we all know that we're getting the right outcomes, because it is a bit of a jigsaw puzzle, and so co-design really has to be built into that. And so getting that data right is absolutely key. And I know from the New South Wales Mental Health Commission's perspective, our role is about providing advice, independent advice to government about mental health reform and about holding up a mirror for government to see. But sometimes that mirror is really a cracked mirror, and sometimes some of those pieces are a bit opaque. And that's because we don't have the data and we don't have the information that we need to know if things are going right. So at the moment, I'm travelling around New South Wales trying to hear from people about what's working and what's not working. And a lot of that also resonates with what you've been saying. People saying that my life was turned around by a program and it's closing at the end of June. I hear that over and over again. I hear that so this week I've been in Tamworth, Singleton, Newcastle and Gosford. And so in Singleton, I heard I can only get down to Maitland because that's where the outpatients clinic is, but there's only 1 bus in and 1 bus out. So how can I get to my appointment and drop my children off at school at 9 and be back by 3? So these other things that we really do need to talk about, and I think which you also identified, that there's that social context of where we live. So I might leave it at there.
Thanks very much, and good afternoon to everyone. And yes, thank you, Stephen, for your address and for the inquiry that you're undertaking. I think there's such high expectations and such a great deal of anticipation, I guess, as to what is going to come out of your process. So there's a lot a lot weighing on it, but what you've said today really, for me, demonstrates that you're really grappling with the issues and understanding very much where the challenges and the problems are. So I guess what I would say is one of the issues will become, once your report's completed, how do we make sure that the recommendations that you make, which I'm sure will be very sensible if it's based on what you've even told us today, and I know you've got a lot more work to do, how do we make sure those recommendations actually get implemented? Because that is always the challenge with these reports, and it is about getting governments to embrace the recommendations and implement them. And it's not always, I think, from a position of ill will on the part of governments, but it's just that these, while they can sound simple in terms of what the solutions are, the reality is to implement those solutions is very, very difficult in our complex system of Commonwealth-state relations, financing, public, private, community mental health services. So that's one challenge. I guess the other issue that I would say is that very much from where I sit, all of the things that you have indicated are correct, and we certainly do need better integration of services. We need to make the system easier to navigate. We need to ensure that there are those services there for the missing middle. But I do think that what sits underneath it all is that there needs to be more resources in the system as well. Certainly, if we're going to address some of those issues, and I think some of the pressures that lead to services not working as well together as they should, that lead to perhaps a division between non-government services and public mental health services, or that lead to cost shifting between state and Commonwealth and the other way as well. A lot of what underpins that is scarce resources, and therefore people trying to find ways to do what they can within those scarce resources that impact less on them rather than on some other service provider or some other level of government. That doesn't make it right, but that is what drives a lot of that behaviour, and we have to see that change. So they're my comments, and I look forward to the questions. Thanks.
Thanks, Carmen. Lucy Brogden from the National Mental Health Commission. I got a note on Friday to remind me that we are still in caretaker mode, and I am not allowed to use any adjectives, which really doesn't sit well with me, so I'm kind of fast forwarding to Monday and hope that Chatham House rules prevails a little bit. But thank you, Stephen, for the presentation. To get to have Stephen up here was 4 years of hard slog by many people to actually get a referral from government to get the Productivity Commission to be looking at this space. And the thing that really pleases me most about the referral and the focus that the Productivity Commission has is on the social determinants of health. The draft terms of reference went backwards and forwards. Social determinants were in, they were out, they were in, they were out. And really it took quite a heavy conversation with the Department of Health as to why they kept taking social determinants out. And it came from a place of fear because they don't control education, housing, employment, etc. And we said, that's fine, don't worry about that. Other people do. That isn't your job. But for us as a system, we need all those other levers in there. We need them in the conversation. And so to finally see the whole picture being looked at is, I think, very exciting and very gratifying. And really the recognition of advocacy from a number of people in this room for years and years and years to get to a place where we're looking at the whole big picture approach, which I think is very exciting. And I think it's interesting when we look at these opportunities that there are so many touch points and enablers, and so many people excited about the opportunity to be part of that change. The challenge we see in the missing middle and the frustration I have when I look at policy at the Commonwealth level and at the states levels is that if the Commonwealth comes in, the states see it generally as an opportunity to retreat. And so we have this missing middle, but it's a moving middle. It's hard to get the midpoint to stay. If the states bring something in, then the Commonwealth says, oh, that state's fine, we don't need to invest there. How do we get that true partnership approach of the states and Commonwealth to work together? Co-commissioning, I think, has some potential, and it'll be interesting to see how it plays out, but it is so frustrating to sit in some conversations where literally, as Stephen touched on, the PHN and LHD won't even meet together. and haven't yet met together, for example, on their suicide prevention plans. People are dying, and they are filling out bureaucratic forms as to who should attend that meeting. So I share your frustration. I've tried not to use too many adjectives and now give you the chance to ask questions.
Thanks, Lucy. Thanks, everyone. All right, you're our first one. You brave it up.
Okay, this is more a comment for Dr. Stephen King. I'm glad you brought up the GP referral program. I was, well, in some ways lucky. I was diagnosed with schizophrenia and I was getting the 18 visits under the GP referral program, and at the time I was lucky enough to be in employment, so I also had private health insurance and an additional 6 visits, and I found that was good. And now the 10 is nowhere near adequate, and the public system, the community mental health, is far too quick to admit people to an inpatient unit, which is more costly. So if there was more cost injected into the gap in the middle with the GP referral program, for instance, then hopefully that would save money on the hospitalisations, which I'm told are $1,000 a night.
Yeah. Yeah, perfect. You know better than I do. But my only comment is that's exactly, in a sense, you're again highlighting that there's a whole bunch of services missing there. So the GP pathway, you know, if you've got a good GP, it works well. There are some GPs face incentives that are not aligned with giving good treatment to people with mental health issues, and that's a problem. Then, as I said when I mentioned better access, I've talked to clinicians. I know that they are providing services essentially outside the scope. So formally, under better access, they're only meant to be doing CBT. Clinically, they should be dealing with patients who need 6 to 8 CBT sessions. The number 10 apparently was some sort of government decision. It was 18 and it came down to 10 for financial reasons. But you know, they're trying to help people who they can't under the constraints of the system. They're the allied health professionals, psychologists and so on. And of course, when that doesn't work, as you said, you end up down the other end of the spectrum in the public hospitals, which is just a terrible waste of money. We need the services in community to be able to deal with that missing link.
This is also a question for Dr. Kim. In your presentation, and forgive me if I didn't hear, but what role do you see for the families and the community would play in the care of a person with a mental condition?
And please feel free to answer and jump in on any of these. I should pass it. Okay. So, you know, when we're talking about mental health, as we've heard today and as we've heard in our meetings around the country, you need support. It's not a broken arm where you go and have a cast put on, an X-ray cast, and the cast is taken off at some other time. You need support. You need support network. If possible, you need a supporting family. You certainly need supporting carers. You need supporting friends. Without that supporting network, it's much harder to deal with mental illness and to recover from the mental illness. So we recognise that. I guess why didn't I mention that explicitly during my points? I guess I was trying to point out where there's real problems in the system. There are issues of carer support in particular, carers' own mental health. Those sort of things we're aware of and we will address, yeah.
I was much more relating to the big gap in informing families about the condition of loved ones, like teaching them on diagnosis so they know what they're dealing with.
Okay, so actually, yeah, so the educating the family. That is something I haven't, I'm not sure, I'm sure somebody on our team is looking at that, but I haven't looked at that I thought you were about to go informing families. We have to, there is an issue that has come up, which is sometimes the person with the mental ill health doesn't want their family to know, and we have to always respect the rights of the person with the mental ill health.
Hi, how are you? I just wanted to maybe just add a point, which I think you were kind of picking up about, and maybe it's a bit like really about mental health literacy, to sort of understand what's happening in your family. And I know this is what I hear a lot, where especially for parents who may have a teenager and they're saying, I don't know, is this what a usual teenage angst looks like, or is this actually something more? And I think it comes back to that navigation and that, as I call it, that soft entry. Like, do I go see my GP, but does my GP actually understand whether this is something that I really should think about? And I think, Stephen, you did raise around the roles of schools, and I think that is really important. How do we get that? Because I know it's also been said to me, so I don't know, is this when I go to Headspace, or is it not when I go to Headspace? I'm not really too sure. And I think it makes parents who are obviously anxious and worried for the person that they love. We all know that early intervention is the key, so getting in early, and that can be whether it's also young in a person's life, or when the parent themselves might be distressed about what's happening in their family. And I think that does then go to the whole productivity of the family, doesn't it? Does a mother then take more time out of work, or then when a mother or father are at work, can they get time off to take their child to appointments? So yeah, I think it's a good point.
I'll let on to that. So I think it's going to be interesting to see how the new eating disorders model plays out with the MBS item, because they have put family and carers into the mix. I've got to say, I thought the whole MBS review for mental health was incredibly disappointing, and I think really reflected poorly on the clinicians advocating in that space, and it was the only panel that didn't resolve at the end of its time, and I think really that reflects on all of us in a way, and we need to own that, because it took a very narrow lens to it, and it needs to be broader. We need that capacity. I also think there's greater advocacy around, and I think actually using the eating disorders model as the wedge is going to be a very good way of doing that, looking at a short-term interim carers payment for parents, particularly if they are looking after a young one and need to take some time out of work to participate in that and be able to have that flexibility. The workplace is a great opportunity for some of that. The number one reason people ring their employee assistance program is parenting issues of teenage children. So what a golden opportunity in a workplace to start developing some of that mental health literacy and to also ease the cognitive load of their employees. So I think we need to get more creative and think about more opportunities.
Just got one up the back here, Mitch.
Dr. Stephen King, there's a factor that I've got a fire in my belly about, and or a frustration that I'd like factored, and that is you mentioned one of the multinationals being the insurance companies, and we missed out here on the big multinationals, the pharmaceutical companies who are providing us with the medications. In the cost to me of the side effects, the contributing side effects from the medications I was taking disabled me out of the workforce. I had to access my superannuation, so that was a cost to me. That I had a good run. I worked for 35 years. So where the multinationals are disabling society, where the insurance companies are denying claims, Centrelink is catching the fall of all these people going bankrupt if they don't have superannuation, because the side effects are disabling. We can't function in society. We end up in Centrelink. We end up in all these organisations and supports. That's our support network. So there's a number of contradictions that are there, because I'll go on to the second one. Working and having a good run and I was 5 months away from long service leave. I was marched into the office. I had been playing policy ping pong for 2 years to keep my job because they cannot sack me for having a disability. Again, we go to the multinational, the insurance company, and they say, but you're a liability, so we can't actually give you any work. We can't sack you, but we can't give you any work. And they march me in the office and say, well, this is about your termination, but I know they can't sack me. So I say, can you provide me with a separation certificate? Oh no, we can't do that because we can't sack you. And I said, well, Centrelink want a separation certificate. And I said, well, are you asking me to resign? And they can't force me to resign, but they can't give me any work. So there's this, because I disclosed, and there's a contradiction in whether I disclose or whether I don't disclose, and how I'm going to be treated, what rights I have that are not binding, and I fall into the hands of Centrelink because of medication side effects, contributing factors. They can't sack me, but they up the bullying to bully me out of the place, which is not what they practice. They don't practice what they preach. I report that to the insurance company that I'm being bullied, who deny the claim that I'm being bullied, and I end up in Centrelink again, and no superannuation. Sorry, it's a contradiction that hasn't been factored in. They're all financial costs to me.
Yeah. Yeah, so, I mean, there are financial costs that come in to people with mental ill health at all sorts of stages just to get appropriate treatment. And I recognise that it's sort of a clinical side I don't want to get in. Oh, sorry, were the drugs PBS listed, so the problem was the side effects, or was it also the cost of the drugs, of the medicines?
No, it wasn't the cost of the medication.
Okay.
You're not hearing what I'm saying.
No, sorry, I just wanted to cut off.
It's the fact that the smart people, the multinationals, have got all the money. The insurance companies got all the money. They deny any claims compensation. They deny any assistance, but they've disabled me. Centrelink is catching the fall. The government is paying that cost for the mistakes of the smart company multinationals that have got all the money. But Centrelink is fronting the cost at the government expense for all these people that have no net to catch them, right? But I had a net to catch me, and that was my superannuation, but that's come at my cost. But I've still ended up in Centrelink. But the pharmaceuticals are Cheshire cats with all the money, and so are the insurance companies, but they'll deny a claim, they'll intimidate you because you've got a mental illness, and it was the side effects of the medications that disabled me and ended me up in Centrelink, but they got all the money and Centrelink's paying for it.
Thank you, Simone. In the interest of time, because I know we're running very over time, I'm just going to ask if we keep it to specific questions if we can of the panel. I'm sure we could be here for hours. We all have things we want to say. You can get off our chest, absolutely. But we are very over time at the moment. So I just got one over here from Satu.
Well, my question relates to this communication and establishing a real contact.
Please.
Oh, okay. It's about the communication and establishing a real contact with a person, as we have heard from so many people how important that is for getting better. Now, so how can we get all these people in services, from schools up to actual mental health services, Centrelink, etc., all the staff there trained actually to be able to communicate with the clients as they come, be with them, hear them, listen to them, and actually understand what they have to say. There is the open dialogue, of course, which is now done in Sydney, at Sydney University. They are actually training people, their staff, to do exactly that. But it should be everywhere. Thank you.
So I'll do very brief on that, then pass on. Workforce issues are something that we're very much aware of, although I didn't touch on it here. And someone earlier today did mention how the clinical evidence appears clear. If you are working with, say, a psychologist or say a therapist who you relate to, that you can have that conversation with, then yes, you are much more likely to get effective treatment and recover than if that relationship isn't there. And that goes down to a basic workforce issue.
I was just going to say the other thing, and I entirely agree with you, and that is about training for the broader workforce to have an understanding of mental health issues, the role of trauma, the way recovery works, all of those things, because at the moment I think there's a lot of people who are working with people with mental health conditions who don't understand these issues at all. I mean, we've just done some training with the NDIA to try and ensure that their planners are better aware of these issues, and the feedback we've got from the training has been extraordinary from the NDIA staff themselves, because they have not had this type of training, and it has dramatically improved their understanding and ability to do the job that they're supposed to do. So I just can't stress enough the importance of training.
And I think the workforce is huge, and the workforce strategy is so key. We don't have a mental health workforce strategy for Australia, and the States don't have one either. And we need to look at not just the numbers, but the nature of the training that goes, whether that's at the peer workforce or the clinical workforce. There are these gaps. We keep talking about, for example, trauma-informed care as though it's another certificate you add. I'm yet to see anyone that doesn't come from a place of trauma. Why that is not a core competency in 2019 is just beyond me, and I think that's where we need to get to.
Cool. Okay, so we're going to go 3 more. And considering you have all Trump veto rights here, not Trump as in the bad Trump, as in the good one, you get to ask a question.
Thanks very much, Liz. We've heard about dancing between parents and children. How are you going to govern the dance between federal and state department and department?
And the multinationals.
Even in caretaker.
In caretaker, I'm going to be really brave. But I actually think it needs the Commonwealth and a state or states to say, you know what, we're going to tackle this together. And it's going to take 2 ministers that sit down and start saying to the PHNs and the LHDs, it is not good enough that you have not had a meeting. I do not want to hear about the forms that need to be filled in to agree at which office you meet at. This is important, and we're going to do it. And that's that level of, we talk about, the thing that frustrates me in the 5th plan is it says government should. Should what? Governments must. The language is so soft. The opting out is so easy. The vagaries. The cross-border health agreements don't cover mental health. How on earth do we write a cross-border health agreement that doesn't include mental health? The fact that it has to be added in kind of shows culturally where we're at, that needs to be added in. It's not implicit in a cross-border health agreement that it includes mental health. So I think it takes that level of 2 ministers actually saying, we're going to play nice together, 2 as a minimum, or more, to say, you know what, let's see what we can achieve. Ireland did a great job at bringing down their suicide rate, and one of the things they did was that the President said, you know what, every minister around the table has a KPI for suicide. You all need to come back to me with a suicide prevention plan. The Minister for Planning needs one, the Minister for Housing needs one, the Minister for Education. Whole of government, I think, is the
I was just going to say we need to go from a disco to line dancing.
So we've just got a question up here, and then we've got one more after this.
So that's exciting. I'm my second last. Lots of thoughts and comments. My name's Arani Sott and I'm a carer. I was originally a carer of a son who had an intellectual disability and autism. That was really easy, really easy. And then 10 years ago, he had a first psychotic episode. That wasn't so easy because we're then in the mental health system and he's got intellectual disability plus psychosis. So anyway, I've been really, really heavily involved as an advocate many years around disability, mental health, care issues. I know I've met a lot of people. I suppose what I wanted to say was 2 weeks ago I was at this forum to fix the NDIS and there was a lady there who said we should really change the name to the National Disability Investment Scheme, and that resonated. And I have done a comment into your, Dr. King, I did a comment which reminds me I've got to put in a submission, but I have done a comment into your productivity study around how it's affected my employment and obviously the employment of my son. So I suppose the fragmentation is the biggest thing, the silos, and from 10 years ago to now, and I was part of the National Register of the Mental Health Australia. I was the only carer on the NDIS Mental Health Sector Reference Group for 2 years, and I never really felt, I never believed that Partners in Recovery and FAMS should have, the funding from that should have gone into NDIS, and I'm just going to say that again publicly. And I also felt that, anyway, I'm getting off track here, but to take an umbrella view, and I'm an economist by training, but to take an umbrella view and a whole of country view, like Lucy said, a whole of government, whole of country view, we need, from the result of your work and everyone's work, we need a mental health investment scheme. So that's,
Yeah.
and that will just bring all the, and the focus is on investment. It's on people getting jobs, on people having a contributing life, the right word, and being connected,
Yes,
and having that.
multinational.
So, and I don't see any problem in having the two things going together, because I don't think the 56,833.5 people with psychosocial disability that are in the NDIS, it is not going, it's just making that gap, that middle bit is going to be, it's 2 million people that are going to fall through the gap. And at the NDIS, my son has an NDIS package, of course I self-manage. You know, it's not going to work. It's just really, we're going to see a lot more bad stuff happening.
I want to say, I agree.
Hi, we are from the Great Lakes Mental Health Care Support Group, and we're just wondering how we can have a voice in regional areas to make mental health facilities better in all regional areas.
That's you.
Hi, where did you say you're from?
Great Lakes.
Great Lakes. Excellent. Excellent. I think I might be coming up there soon. Look, it's a really good point, isn't it? It is about inclusion, and it's also about you knowing where to go to be involved. And I think it comes a bit back to what Lucy was saying earlier about how the LHDs work with the community and how the PHNs work with community. People, you know, each of those groups are supposed to have advisory groups, and they're supposed to be inclusive. They're supposed to have paid participation. Don't get me started on that, because I know they don't always do that. Oh, okay, yeah. So I guess the thing is, you either do a bit of advocacy and you agitate locally, but I think the thing for the New South Wales Mental Health Commission is very much around inclusion. And I'm always happy to talk to a CEO every now and then and just say, you know, look in your own backyard. So happy to do that.
We did get a reply from Tanya Davis saying you're being accepted on the CPU, so you'll make changes there after we put in a submission for the area. And that's not the platform to use because they're area problems.
I'm sure you're doing this, but one thing I was going to say is to really utilise as a local member your right to go and see your local member of parliament, federal and state. It may not immediately. It's true. You don't get an immediate response, but I can't underestimate how much it does make a difference, particularly if you do it on a regular basis for your local member. Because it does increase their understanding of the issues, and the first time their response might be a little bit, you know, not terribly helpful, but the second time you might get a bit more, and eventually they are going to be part of a decision-making process about the issues that you care about, and if you've been able to educate them, they will make a better decision. So I know it can be painful and you feel like you're just, you know, bashing your head against a brick wall, but it is really important.
Local members are ex-cyclists, so who better would understand what we're talking about?
Yes.
That doesn't get through.
Just keep trying.
Now,
Seen the submission to the Mental Health Commission originally, nothing happened. We were at Newcastle when you were there, and we did give a copy to the lady that you were with the other commissioner, and nothing happened there. So then we went to Stephen Bromhead and asked him to send it on, and then it went from Breakup to Tanya with a very apathetic reply, and we're on as many, we do the support group, we're on the CPU, we're on the Family and Carers Committee at the hospital, and nothing's happening.
Well, it sounds like you're doing amazing things, even if you're not getting the outcome that you want. It takes a long time.
no, I just want to jump in. We have run out of time. I'm really sorry. We're very, very over time. However, the suggested panel topic was to do it better or do it differently. So I'm going to wrap this up by asking each of the 4 panel members, do we do it better or do we do it differently?
Without suggesting the directions that we're going, we do it differently. You can either take an incremental approach. From what I've seen, I think we need more than an incremental approach. I don't think that's going to get us.
Yeah, I totally agree. I think that it's taken us a long time to get to this place that we are. You know, when you think about when those guys in boats sailed into Sydney Harbour, and we started a period of colonisation and institutionalisation right from the very, very beginning of white settlement. It's taken a long time, and I think we have institutionalised our thinking. And I think across all the questions that we've had today, to me is institutionalised discrimination. And I think that's the big thing. How do we shake up our systems? And I think funding levers are very good at that. If there are KPIs with funding that say that you must co-design, you must see the whole person, you must be family-centred, you must understand that it's not good enough just to give someone some medication without medication review. That it's not good enough if they have medication without having the right number of psychosocial supports or to have the right number of services under better access. Because we all know that it is not only about integrating the services, as in the providers, it's about integrating the services around the person. And that's why it has to start. So I always call it a bit of a donut. I think that sometimes we kind of keep looking through the middle trying to find the answer, but the answer is there. It's that circle. It's about wrapping everything around together.
I think this one works. Yes, I agree. I think we have to do it differently so we do it better.
I think we've got some really big bits that we don't want to lose, and this is the frustration. You know, PIR was humming And I won't tell you about the conversations with the Department of Health when they came up with this really whiz-bang idea recently, and we said, yeah, that's called PIR. And they said, oh, have we done that before? Yes, we have. So we need to keep and capture the stuff that is working and is good. It needs the evaluation and the data, and that's where the data boffins, we get excited and why it doesn't seem terribly sexy, but we need to take that good stuff and serve it up so differently that it actually gets out to the people in the community. And I hadn't actually realised, just I know you want to finish up, but we talk about the fence or the ambulance at the bottom of the cliff. And I only recently discovered that comes from a poem written by a doctor, and he was talking about public health generally in the 1880s, I think it is. And to go and read that, and the premise of that really shows that it takes a community to keep us all well. And we need to really think about standing at the top rather than looking up from the bottom all the time. Thank you.
Thank you so much to our panel members. I would ask Lucy to stay with us on the stage and ask Kathy to join us on the stage. We're just going to do something a little bit fun to wrap all of this up.
Do you hear and understand?
All right.
About the community.
Lucy and I now got to sing.
Yep.
Yeah? Alright, here we go. So before we wrap up today's agenda, we have the opportunity of signing the National Communications Charter with Lucy Brogden here to oversee this. The National Charter has been designed to guide the way organisations, governments, community groups and public figures talk about mental health and suicide prevention. The Charter supports respectful and consistent messaging around mental health and suicide. Hosted by Life in Mind Australia, the Charter can be signed by anyone who believes in the principles of the Charter and who are prepared to adhere to and act on its guiding principles and messages. As the signatory of the Charter, you're making a formal commitment to communicate in ways that actively work to reduce stigma, increase help seeking and collaborate with each other and the wider community to maximise efforts and resources. That is awesome. I would like to get Kathy Borman and to join us on stage to sign on behalf of the One Door Mental Health.
And I think this is just fantastic thing and for us as an organisation to stay committed to. And I think it's a lovely thing to end on. Mind you, I think we could have drilled these 4 people for another 2 hours at least. Capture them, they'll be having a few drinks, so yeah,
Thank you for doing that. I think language really, really matters, and it was interesting prior to the election campaign that Life in Mind and a group of people actually went to Canberra and got a number of the politicians to sign a language pledge in terms of thinking about the language they used in the campaign. And I think to some respects these things are much more than just tokenistic. They make people stop and think about language and the impact that language has. And we've come such a long way, and Australia really leads the field in being sensitive to language and mindful of language. But there's always opportunity to do more. So thank you for being part of this. I'm proud to be an ambassador for the Charter. Thank you.
And anyone who wishes to become a signatory of this Charter is welcome to do so during the networking hour. So a Life in Mind table's in the foyer with more Charter certificates, and someone will be there to oversee this and take photos. So that's it. Thank you everyone for giving up your Saturday to be here. I've found immense value from this. I don't think we could get a better action-packed agenda. Yeah, we want to plug this idea cloud. So one idea, so we've got 100 ideas to push forward, right? We'll distribute through email, or we'll collect them out the front. Thank you very much everyone, have a good rest.